Is my screen visible?
Yes.
So we'll start the class straight away. So today's discussion will be on antimicrobials. So whenever you use the term antimicrobials, it's a common term which includes antibiotics which acts against bacteria, antivirals which act against viruses like HIV, HBsAg, HCV, etc., and antifungals. These two we are not going to deal today. We are going to deal entirely about antibiotics. So whenever you are dealing with antibiotics, in what are the situations we use antibiotics? First is prophylactic therapy. Just a few basics before we enter the actual topic. Prophylaxis is patient does not have infection. Okay. Since there is no infection, he does not have the disease. But we are suspecting that he may develop infection due to some action. For example, we are going to do a surgery for a particular patient. We are suspecting that he may develop an infection in due course because of the surgery. So we are giving one antibiotic for him to prevent occurrence of infection. It is called as prophylactic therapy. So other prophylactic therapy. So this is surgical prophylaxis. Examples for medical prophylaxis include infected endocarditis prophylaxis. Okay, so by the term prophylaxis means he does not have infection, he does not have the disease, but he is more prone to get the infection. So we are giving an antibiotic. So just one quick point. So infected endocarditis prophylaxis, the current indication is prior infective endocarditis. In not all indications we give, only for prior infective endocarditis and prosthetic valves. These are the usual two indications where we give infective endocarditis prophylaxis. Not for all valvular lesions, we do not give infective endocarditis prophylaxis nowadays. So in what situation we give is prior to some respiratory procedure, like a tooth extraction. So we are planning for a tooth extraction. He's having a prior infective endocarditis. We give him some antibiotic to prevent infection. We'll discuss what antibiotic later. Similarly, we have SBP prophylaxis. So patient is having a nephrotic syndrome or a chronic liver disease. He is at high risk of getting Escherichia coli infection. We are giving antibiotics for it, like a ciprofloxacin. It is prophylactic. So remember, prophylaxis is patient does not have infection, patient does not have disease, but is prone to develop infection. So we are giving antibiotics.
Okay.
The next entity how we can treat is preemptive therapy. Patient has infection. Okay. So the organism is within his body, but it has not caused the disease yet. But still we give antibiotic or an antimicrobial. One classic example is patients with renal transplant. If they develop CMV infection, even without clinical manifestations of the disease, we are supposed to give Valgan cyclone. I think the dose is 900 BD. So this is preemptive. Patient is having infection. He does not have the disease, but since it can develop into a disease, we are giving therapy. This is not prophylactic therapy, please remember. Prophylaxis is he does not have the infection at all. Next comes our favorite topic, which is going to be discussed today in detail, which is empirical therapy. Empirical therapy is he has an infection. Okay. He has a disease due to the infection. We are giving antibiotic to treat him, but in this case, we do not know the infection. The patient is having an infection, patient is having the disease, but we do not know what organism is causing the disease. So we are giving antibiotics provisionally, considering particular organisms. The entire the entire talk of today will be based on this empirical therapy, how to choose empirical antibiotics for a particular patient. But the best way to treat infection is definitive therapy. Definitive therapy is patient is having infection, patient is having the disease, and we know what organism is causing the disease. We know the susceptibility also based on the culture sensitivity report. So we are giving the particular antibiotics to target the organisms based on the culture sensitivity report. This is definitive therapy. So why the question of empirical therapy and definitive therapy comes is, which is the best one? According to me, definitive therapy is the best because we know the organism, we know the susceptibility. In fact, we know what concentration of the drug is going to kill the organism. So always the best therapy to treat an infection is definitive therapy. But for all practical reasons, definitive therapies cannot be practiced much because it takes 2 to 3 days for a culture report to come. But most of the infections in the current trend are very serious. So we'll be forced to start empirical antibiotics. And most of the guidelines say for few infections, we must start empirical antibiotics. We need not wait for the confirmation. One is community acquired pneumonia, we must start empirical antibiotics. So if patient is having a pneumonia, with a community acquired pneumonia or a hospital acquired pneumonia, we are not supposed to wait till the culture report comes. Similarly, sepsis. You know the definition of sepsis. If there's a sepsis, we must start empirical antibiotics. Next is necrotizing fasciitis. So these infections do not wait. If the patient is having such infections, we must start empirical antibiotic and we must not wait for the culture. So you can see very well here, few things are not covered. AG, as per guidelines, even meningitis is not covered. UTA is not covered. So just a plain cystitis, patient is having a cystitis, we can wait for at least 2 to 3 days till the culture sensitivity comes. So why we should know about all these terms is only to the practice a particular entity called as AMSP, antimicrobial stewardship program. I'll just touch upon this very later in the discussion. We have to give antibiotics ideally. That is the entire idea of antimicrobial stewardship program. So unnecessarily giving antibiotics is bad. Avoiding necessary antibiotic is also bad. So we'll discuss the aspects later. So this is about the various therapies which we give with antibiotics. Okay, so what is today's plan of talk? The plan of today's talk will be initially we'll be discussing about just some basics about microbes, how to classify them. Then I'll tell you what diseases are caused by the microbes. They are called as infection syndromes. Once you know about the infection syndromes, then I'll introduce you to about the various class of antibiotics, not the entire details, just the spectrum which each antibiotic covers. Only if you know what antibiotics cover what organisms, you can treat or you can think about treating infection. Then we'll do some match. I'll tell some syndromes. You are going to tell what antibiotics can occur. Finally, at the end of the discussion, we'll just discuss the 2022 ICMR antibiotic guidelines. Okay, so this is just a warm up. These 10 minutes. So another 10 minutes also is a warm up only. Microbes. Microbes, as I told you, we are going to discuss only about bacteria. We are not going to discuss about viruses, fungi, protozoa. So how do you classify bacteria? Basically, gram-positive cocci. You can stop me in between whenever you are not able to follow. Gram-positive cocci, gram-negative cocci, gram-positive bacilli, gram-negative bacilli, TB-like organisms. So mycobacteria, they are called as. The mycobacterial spectrum of bacteria, atypical organisms. Spirochetes. So this is a crude way of classifying microbes. So this you have already learned in a microbiology. Gram-positive cocci includes the two main organisms, Staphylococcus and Streptococcus. Streptococcus pneumoniae is an organism which we call it as pneumococcus. Pneumococcus. So Staphylococcus, Streptococcus, pneumococcus are the three important gram-positive cocci which you should remember. What about gram-negative cocci? Gram-negative cocci we have mainly, in fact, three. Meningococcus, the so-called Neisseria meningitidis, also called as meningococcus. The next is Neisseria gonorrhea, which is called as monococcus. And another one is Moraxella. Gram-positive bacilli. Remember the mnemonic data. D for diphtheria, foreign bacterium diphtheria. A for anthrax. You know, anthrax is caused by Bacillus anthrax. So the genus Bacillus. Quickly, important clinical infection is anthrax. T for tetanus, Clostridium tetanus. Another A for actinobacillus, can cause infective endocarditis. These are the gram-positive. All other organisms which come to your mind come under the huge category of gram-negative bacilli. So starting from Enterobacterium, most of the gram-negative bacilli are in the intestine. So they are called as Enterobacteriaceae. So E. coli, Klebsiella, Salmonella, Shigella, Bermio Vijayakumar, Pseudomonas, Acinetobacter. And what else? If you randomly choose one name, it will fit under gram-negative bacilli. Okay, Helicobacter pylori. If you put any random name, it will come under gram-negative bacilli. So most of the bacteria themselves are gram-negative bacilli. So at least remember gram-positive, gram-negative, and gram-positive bacillus, so that you can remember the remaining as gram-negative bacillus. And TB-like organisms, three mainly: Mycobacterium tuberculosis, which causes TB; Mycobacterium leprae, causes leprosy; and we have so many called as NTM, non-tubercular mycobacteria, or atypical mycobacteria. We are not going to discuss this today. Atypical organisms, we have Mycoplasma, Chlamydia, Rickettsia. Okay, so remember at least these three atypical microorganisms. Of course, there are others also. Legionella is also an atypical organism. What do you mean by atypical? They are intracellular rather than extracellular. So most of the antibiotics which act in the bloodstream do not cover these organisms. We need intracellular antibiotics to act against these. So this is about atypical organisms. And spirochetes, you know the examples. The typical example is syphilis. Treponema species, Treponema pallidum, endemic Treponema, then Leptospira, Borrelia, Borrelia recurrentis causes relapsing fever, Lyme's disease, etc. Right? So this is just a summary of the common bacteria which we come up, right? So the next part of the warm up is I told you about the various organisms, the common bacteria which are present. What infections do these cause? So before that, I'll just tell you something called as infection syndromes. Whenever you are treating an infection, or when you are treating a patient in critical care, if we are going to label as infection, always label them under one of these infection syndromes. For example, CNS infection is a broad syndrome. Okay, so if a patient presents with fever, headache, vomiting, altered sensorium, photophobia, etc., clinically this fits under infection syndrome of CNS infection. It could be meningitis, it could be encephalitis, it could be a CNS abscess, okay, brain abscess, or if the patient is already in a shunt, BP shunt, it could be a shunt infection, something. So this is CNS infection. So from head to foot will come. Below the head, we have the nose, ear, nose, and throat. So ENT infection comes under upper respiratory tract infection. Upper respiratory tract is from your nasal cavity, oral cavity, up to the larynx. Okay, so till laryngitis. Infection of the larynx is called laryngitis. So an otitis media, otitis externa, rhinitis, sinusitis, pharyngitis, till laryngitis is upper respiratory tract infection. Below the larynx. Okay, so below the larynx we have trachea, tracheitis, bronchitis, bronchiolitis. Infection of the lung parenchyma is called as pneumonia or pneumonitis, right? So pneumonia. So from tracheitis, bronchitis till pneumonia we have lower respiratory tract infection. So below the lungs we have the GIT, intra-abdominal. Okay, so intra-abdominal infection, again it could be something related to the intestines, like gastroenteritis. If the colon is infected, we call it as colitis. So this is the intestine getting involved. Suppose the solid organs are involved, like hepatitis, splenitis, or splenic abscess. That is another syndrome. Or the peritoneum may be involved. That is peritoneum. I'm not telling all the syndromes. I'm just giving you an overview of how to classify the syndromes. Similar, another important organ within the abdomen itself is the urinary tract. So UTI, urinary tract can be from the lower urinary tract, like an urethritis or a cystitis, or upper UTI. Upper UTI includes involvement of the ureter, the renal pelvis, or the kidney. Involvement of the renal pelvis is called as pyelitis. Involvement of the kidney is called as nephritis. Usually they occur together, so we'll call it as pyelonephritis. The next stage of pyelonephritis will be a renal abscess, perirenal abscess.
So can you repeat that upper UTI again?
Lower UTI is clear. Urethra is involved, urethritis. Then above that is cystitis. Upper UTI is the ureter doesn't the ureter doesn't get involved usually alone. The renal pelvis gets involved. Inflammation of the renal pelvis is called as pyelitis, whereas inflammation of the kidney tissue is called as nephritis. But usually they both occur together, so we use the common term as pyelonephritis. Okay, the term pyelo means renal pelvis is inflamed. Nephritis is the kidney is inflamed. So when the kidney gets inflamed, the inflammation spreads outside. So that is what is called as a renal abscess, perirenal abscess, those things. So after this we have RTI, reproductive tract infections. We are not going to discuss this today. The females it will be vaginitis, cervicitis, pelvic inflammatory disease. Males again it will be prostatitis, epididymoarthritis. So okay, after this we have SSGI, a very important group, one of my favorites, skin and soft tissue infections. The skin and soft tissue example will be cellulitis, skin abscess, erysipelas. and most important, necrotizing fasciitis. I told you, necrotizing fasciitis is one instance where we must start empirical antibiotic. Okay. So after skin and soft tissue infection, we have BJI, bone and joint infections. Infection of the bone is called as osteitis. Infection in the inside of the bone marrow, is called as osteomyelitis. Okay, so osteitis is actually infection of the bone. Infection of the bone marrow is called as osteomyelitis. Infection of a joint is called as arthritis. If it is due to infection, specifically we call as septic arthritis. The entire thing is connected by blood. So yeah, another category called as bloodstream infection. Okay, anything in the blood is called as bloodstream infection. Infective endocarditis is a part of the bloodstream infection. Okay. There's something called a septic embolization. Like if there's a brain abscess, you should suspect the infection is present in the blood. You have to look for some source. So that can be grossly grouped as a bloodstream infection. And the last category is HAI, healthcare associated infection. You can label anything: ventilator associated pneumonia, healthcare associated pneumonia, CLAPSI, CRIPSI. CRIPSI is catheter related bloodstream infection. So any catheter we have put, that can be infected. CLAPSI is central line associated bloodstream infection. So it can come under bloodstream infection also, but mostly this is a hydrogenic or a hospital acquired infection. The last syndrome is sepsis. Whatever be the infection, define sepsis. Anyone? Sepsis is not infection. Yeah, dysregulated post response to infection.
Post response.
Yeah. So till now we are discussing only about the infection. When the body tries to fight it, and the body becomes dysfunctional because of that, like the body secretes more of an inflammatory mediators. Those inflammatory mediators cause vasodilation. Those cause some problems. Then we call it as a sepsis. So treatment of sepsis is different. Again, today we are not going to deal much about sepsis. It's a separate guideline. We have separate guidelines also. Surviving sepsis campaign guidelines, 6th edition, I think. 6th or 5th, I'm not sure. Okay, clear with this concept. So first you understood about the microbes overall classification. Then I told you about possible infection syndromes which you can classify under. Any doubt till now? Now I am going to tell. Clear, no?
Yes.
Now I am going to tell you what organism is going to cause what syndrome. Okay.
Okay.
So Staphylococcus. Staphylococcus is present in the skin. Okay. So invariably skin and soft tissue. So when the skin gets involved, the immediate structure underneath that is the bone and the joint. So bone and the joint infections can be caused by Staphylococcus. It can go to the blood, so bloodstream infection. So if you remember, infective endocarditis, one possible cause is Staphylococcus. Septic embolization, one cause is Staphylococcus. Any post-surgical, that is neurosurgical. So if there's a neurosurgical meningitis, a shunt is getting inserted, then it could be due to Staphylococcus. Right? So anything involving the skin, the bone and joint, or anything which pierces the skin is going to involve Staphylococcus. So why Staphylococcus is considered very, very important? Just a minute.
Hello. Hello.
Yeah.
Hello.
Yeah.
Hello?
The mute
Hello.
आया.
ഇല്ല
Hello?
ജസ്റ്റ് a minute എന്ന് പറഞ്ഞു.
Yeah,
Okay,
2
okay.
minutes. Okay, so in short, Staphylococcus causes skin and soft tissue infection, bone and joint infection, and anything related to blood. Okay, anything which communicates from the skin to the interior, it is going to cause infection. Regarding Streptococcus, there are many categories: Group A, Group B, Group C. I'll just tell the infections which are caused by them. The main organism is Streptococcus pyogenes. Okay, Streptococcus pyogenes is normally present in the throat. So any respiratory tract infection. Okay, any respiratory tract infection, be it otitis media, pharyngitis, laryngitis, can be caused by Streptococcus. One skin infection is caused erysipelas. This can also cause any skin and soft tissue infection, cellulitis, abscess, can be caused by Streptococcus. Then rheumatic fever. Okay, so these are infections caused by Streptococcus. Respiratory tract infections, skin infections like cellulitis can be caused, and rheumatic fever. So I told you skin and soft tissue infection, to think of Streptococcus and Staphylococcus, both can cause. So can you clinically differentiate both? Means yes. You know very well that Staphylococcus aureus is a coagulase positive organism, whereas Streptococcus is coagulase negative. At the same time, it produces many enzymes called as streptolysins. Okay. So if there's an infection or a cellulitis caused by Staph aureus, it's usually localized. So there's a trauma, there's a localized cellulitis around that area, it is Staph aureus. Whereas there is not much of a trauma. The skin just gets stretched due to some pre-existing edema, etc. There's a diffuse cellulitis, think of Streptococcus pyogenes. Just additional point. Pneumococcus, again, it is present in the respiratory tract. So, any respiratory tract infection. Please remember, any organism which is present in the respiratory tract can ascend above and it can cause meningitis. So, Streptococcus pneumoniae is the cause of meningitis and encephalitis, CNS infection. Even Streptococcus pyogenes can also cause meningitis. This group is very, very important. Okay, so three organisms in gram-positive cocci and the infections caused by them are very, very important. Gram-negative cocci, it is very simple. Meningococcus name suggests it causes meningitis, meningococcal meningitis. Gonococcus, it causes gonorrhea, which is a reproductive tract infection. I told you we are not going to discuss this today. Moraxella causes respiratory tract infections. So at this juncture, another insight is, I'll tell you, the organisms causing respiratory tract infections. Classically, what books say, what Harrison says is three typical organisms and three atypical organisms. The three typical organisms are Streptococcus pneumoniae. So worldwide, the most common bacteria which causes pneumonia is Streptococcus pneumoniae. Next is Haemophilus influenza. Haemophilus influenza is a gram-negative bacillus. I didn't mention here in the list. I told you anything which is out of the list is gram-negative bacillus. Next is Moraxella catarrhalis. This is a gram-positive, gram-negative cocci. Three atypical already we had discussed. Chlamydia, Chlamydia pneumophila, Mycoplasma pneumoniae, and Legionella. So remember this in set. Organisms causing respiratory tract infection. So respiratory tract infection means pneumonia, upper respiratory tract infections, everything. Even they are prone to cause meningitis also. But not all these can cause meningitis. Streptococcus pneumoniae typically causes, H. influenzae can cause, Legionella can cause, the others less likely cause. Okay. So gram positive, gram negative we have discussed. Gram positive bacillus is very easy. Diphtheria is a defined clinical syndrome, nothing much. Anthrax is a defined clinical syndrome. Tetanus is a defined clinical syndrome. This I told you it causes only infective endocarditis. And gram negative bacillus is the next most important group. Gram negative bacillus can cause any infection. Okay. For example, usually the general saying goes, any infection above the diaphragm will be gram positive, any infection below the diaphragm will be gram negative. So below the diaphragm, we have intra-abdominal infections. So diarrhea, enteritis, colitis, abscesses, peritonitis. Okay. Then even urinary tract infection is below the diaphragm. So pyelitis, nephritis, cystitis, urethritis, and even reproductive tract infection is below the diaphragm. Urethritis, cervicitis, pelvic inflammatory disease. And why we are more bothered about gram negative is they commonly cause bloodstream infections and healthcare associated infections. This is the reason why gram negative is given more weightage. So whenever there's a healthcare associated infection or bloodstream associated infection, we should be worried about two important organs. One is gram negative bacilli, especially Pseudomonas. And the second thing is Staph aureus, that too MRSA. I'll tell you what is MRSA later. So whenever there's a bloodstream infection or a healthcare associated infection, these two things we should be worried about and we should give antibiotic to cover these two things. Right? Okay, now atypical organisms we have discussed. Spirochetes, syphilis causes syphilis. Treponema pallidum causes syphilis. Leptospira causes leptospirosis. Borrelia causes Lyme disease, etc. Okay. Got an orientation now? So till now, what I was telling is, what are the microbes available?
Yeah.
What are the infection syndromes available? And what are the possible organisms and what infections they cause? Okay. Now, just a revision question. Okay. Can you tell me what are the organisms which cause CNS infection?
Any
Reverse.
bacteria that can reside in the resides in the
Specifically.
respiratory.
Tell specifically.
Streptococcus pneumonia, Haemophilus influenza.
First is pneumococcus.
First is
Haemophilus influenza. Streptococcus pyogenes, yes, because it is in the
Staphylococcus
respiratory system. Come in order. Gram positive. Can Staphylococcus occur?
Staphylococcus is very rare.
It can occur in case of neurosurgical meningitis.
Neurosurgical, if shunt infection.
Shunt infection is there. Then comes Streptococcus. Streptococcus, you told it can occur. Next comes pneumococcus. You told it can occur. Then tell about gram negative cocci. Can meningococcus occur?
Gram negative cocci, yeah. Meningitis.
Yeah, gram negative cocci, meningococcus. Gonococcus will not cause meningitis. Moraxella, I told you, less likely causes meningitis. Then comes gram positive bacillus. They are defined syndrome, so leave it as such. Gram negative. Gram negative, I told you, mainly below the diaphragm only. So again, they are less likely to cause meningitis. Very rare.
Less likely.
We have one more gram positive bacillus, which I missed. Listeria, okay. It can cause meningitis. Viruses is a separate category. That's all. And can spirochetes cause meningitis?
Yes,
Yeah.
leptospirosis.
Syphilis, leptospira, aseptic meningitis. That's all. So next time, whenever you see a meningitis, you can prepare a list of whatever possible organisms it can cause. now since you have Liston meningitis, now you have to give some antibiotics which covers all these things, which will be the next part of the talk. Okay, quickly. Upper respiratory tract infection, possible organisms.
After respiratory tract infection,
Think in the same order: gram positive cocci, gram negative cocci, gram positive bacilli, gram negative bacilli, atypical spirochetes. Think in the same order.
okay. So Staphylococcus, less likely.
Okay.
Streptococcus can cause respiratory tract
Yeah.
infection.
Streptococcus
Streptococcus pneumoniae,
pyogenes.
that's pneumococcus can cause.
Okay.
Moraxella can cause.
Okay.
Strep-
I gave you 3 typical and 3 atypical organisms already.
These
Oh
are
yeah.
Chest influenza.
Uh,
Can staph occur? Staph can cause pneumonia, but it is less likely. Okay. It can cause, but it is very rare. I'll tell you that in the end. Then
now
atypical
you asked
organisms,
about
I told you, mycoplasma.
now, now you asked about upper respiratory tract infection, right? Can
Both,
Haemophilus influenza now
both.
cause that? Oh, you asked about both.
Respiratory tract infection, usually we tell both only.
Sure.
Same organisms cause both.
So strep, pneumo. Oh, we just need to remember that list. No, typical atypical.
Yeah, typical atypical.
But
Intra-abdominal infections,
in that you have not given Streptococcus pyogenes.
I didn't give that, but it
In
can
the
cause. That's
typical,
why I written. Typical is Streptococcus pneumonia, Moraxella, and H. influenza. As per book, they are the 3 most typical, and the Mycoplasma, Chlamydia, Legionella are the 3 atypical. But apart from that, even staph infection can occur. Streptococcus pyogenes can occur. Gram-negative infections can also occur. We have Klebsiella pneumonia also, no?
yeah.
So they can occur, but they are not the typical organisms. The most common typical organisms they are not. That is why whenever you are treating, we are supposed to treat these 3 organisms plus these 3 organisms first. But if the radiological features or the clinical features show evidence against these things, then you have to consider a different course of antibiotics. That we'll discuss later. Okay, and intra-abdominal infections, I told you to remember all the gram-negative bases. Okay, for example, whenever someone asks what are the organisms which cause diarrhea, gastroenteritis or colitis, E. coli can cause, salmonella can cause, Shigella can cause, Yersinia enterocolitis can cause, then Campylobacter. The list is more, the same restricting here. Similarly, peritonitis, protease, I didn't mention about protease. UTI also the same organism, right? In UTI, we don't get Salmonella, Shigella. UTI, when we say it is E. coli, Klebsiella, protease, common organisms.
Okay.
Okay. Bone and joint infections.
Bone and joint can be staph, strep.
Yeah.
Uh,
Staph and strep. Remember these two. Anaerobes can. I didn't mention
also.
about anaerobes initially.
Oh.
Yeah. Anaerobes I left as a group. Skin and soft tissue infections, all do the same thing. Staph, anaerobes.
Staph, strep also, no?
Yeah, strep also. I written. And any healthcare associated infection, what are the 2 things I told you to remember? MRSA and Pseudomonas. At least apart from that, we have Acinetobacter, etc. At least remember MRSA and Pseudomonas. Okay, shall we move to the next part?
Yes.
You got some idea on next time whenever I ask you, tell you on infection syndrome, what should come to your mind is what are the possible organisms which can occur. Okay, our entire discussion, especially the last part of the discussion of today, during our discussion due of the recent antibiotic guideline, this will be the pattern. A syndrome will be given. You have to think about the possible organisms. You have to think about the possible antibiotics which can cover that and frame a possible treatment schedule.
That
Okay.
should be the
Now
plan.
we'll go to the So we'll go to the second part of today's discussion, which is antibiotic and their coverage. This is most important, so I'll go a bit slow, but we'll finish up very fast. So whenever you are discussing about antibiotics, few things have to be known. One is the most important thing is spectrum. Only if you know if a particular antibiotic acts against a particular organism, you are supposed to prescribe that. So knowing the spectrum is very, very important. Next is pharmacokinetic and pharmacodynamic properties. Pharmacodynamics we are not going to discuss today. Pharmacokinetics, what we'll do is only two things: time dependent killing, concentration dependent killing. Time dependent killing is there are some antibiotics which need to be present for a longer time in the body to have its action. For example, penicillin groups. All the penicillin, cephalosporin, vancomycin, the antibiotic, the concentration is not important. Even if the concentration in the blood is minimal, they have to be present for a particular time in the blood to kill the organisms. That is called as time dependent killing. So another is concentration dependent killing. Concentration dependent killing example is aminoglycosides, fluoxetins, the fluoroquinolones. So concentration dependent killing means it is not a duration of the antibiotic presence which matters. How concentrated it is. So even if it is for a short time, the antibiotic is present, it should be present in high concentration. So for antibiotics which have time dependent killing, we should give them in frequent doses or as infusions. Like to say, if you remember, penicillins will be given in TDS dose or QID dose. Sometimes vancomycin is given as infusion. Meropenem can be given as infusion because of this reason, because it's a time dependent killing. Concentration dependent killing, we should not give them as infusions or TDS dose. They should be given preferably as OD. Let's say if you see my prescription, I'll write amikacin as OD only. Amikacin 1000 milligram OD. That is ideal.
Oh,
Similarly, gentamicin, rather than giving 80 milligram OD BD, we can give 160 milligram OD. So a high concentration in a short time will achieve a concentration dependent killing. Remember, aminoglycosides have another property called as PAE, post antibiotic effect. We give it in high concentration, it will kill the bacteria. The effect will persist for a longer time. That's called as prolonged post antibiotic effect. Okay, so spectrum we are going to discuss. Pharmacokinetics we have discussed. PD we are not. Pharmacodynamics I am not going to tell. That is what's the mechanism of action I am not going to tell. Next, most important thing which you must know is resistance. It's a complicated topic, but it's an exam question for you. At the same time, it's a high practical relevance. There is something called as intrinsic resistance. This part is the most important part. So if you are not able to follow, you can stop me anytime. Intrinsic resistance is some bacteria are not susceptible to any antibiotic. I'll tell an example. Pseudomonas is not acted upon by penicillin. Penicillin. The penicillin is the basic antibiotic, as you know. If you give penicillin for Pseudomonas, it is not going to act because Pseudomonas is intrinsically resistant to penicillin. Similarly, Listeria is intrinsically resistant to ceftriaxone and amoxicillin. So I told Listeria can cause meningitis, but it is not covered by ceftriaxone. So if there's a Listeria meningitis, giving ceftriaxone alone is not going to work. Even if you are culturing the organism and the report is being given as Listeria sensitive to ceftriaxone, it cannot be believed because in vivo, Listeria is intrinsically resistant to ceftriaxone. That's no point in giving ceftriaxone for Listeria. And another basic thing, all gram positive Gram positive means they have thick cell wall. They are intrinsically resistant to aminoglycosides and fluoroquinolones. So aminoglycosides and fluoroquinolones are drugs which are given for gram negative infections. Don't give them for gram positive. Same thing. If a report also shows streptococcus, which is sensitive to amikacin, don't go about giving amikacin because it is not going to work because gram positives are intrinsically resistant. Aminoglycoside is a drug which acts by inhibiting protein synthesis. For organisms with thick cell wall like gram positive, it is not going to penetrate at all. That is why if we are going to give aminoglycosides for gram positive infection, we must give another antibiotic to break the cell wall. All penicillins break the cell. So if we are to give, if aminoglycosides have to work for gram positive, it has to be given with penicillin. So this is the concept
Just
about
a,
intrinsic
just
resistance.
just a second.
Hmm.
So gram pos so aminoglycosides has to be combined with penicillin. If
In infective endocarditis,
it,
the common organism is Streptococcus viridans and Streptococcus and Staphylococcus epidermidis, right? It's a gram
yeah.
positive organism. Since it is a very dangerous infection, it is better if we give two antibiotics. Okay. You know very well the antibiotic combination which we commonly use is ampicillin plus gentamicin. Gentamicin is an aminoglycoside. Ampicillin is a penicillin. We are giving this combination for a gram positive coverage, right? This is the action. Ampicillin breaks the cell wall and allows gentamicin to enter inside. So there are two antibiotics in two different mechanisms for infective endocarditis.
Okay.
Shall I proceed?
Yes.
This is about intrinsic resistance. Similarly, there's something called as intrinsic susceptibility. I think that is clear cut obvious. Next is acquired resistance. Don't be happy about antibiotics, especially in a case of pseudomonas. So, patient comes to the hospital with some syndrome. You do a culture and pseudomonas has come to be positive and assume that initial sensitivity has come to 7%. Okay. Patient initially responded, patient fails to respond after 5 days. Now again, you have a doubt, you repeat the culture, same pseudomonas as known. Now this is so resistant to 7%. So this is a defined phenomenon. This is called as in-hospital acquired resistance. In-hospital rapid acquired resistance. So the same organism in the same site, in the presence of antibiotic, it will acquire resistance in a very short time. This problem is there with pseudomonas. That's why if patient is initially responding to pseudomonas, he fails to respond, he have to repeat the culture again. Repeat the sensitivity again. The sensitivity would have changed. Okay, and you know the mechanisms of resistance. Efflux pumps are there. Inactivating enzymes are there. Whenever we speak of resistance, we always tell about staphylococcus. Okay. Okay, this is a very interesting history. You know this. I'm just repeating for academic sake. Penicillin was the first antibiotic discovered. You know very well that penicillin binds to penicillin binding protein in the bacteria and inhibits cell wall synthesis. This is how it acted. Later, what happened is Staphylococcus became more intelligent and it started producing penicillinase enzyme. Penicillin is a beta lactam. So penicillinase also called as beta lactamase. So beta lactamase started destroying penicillin. So then penicillin started having no action. So humans became intelligent and what they did was they started to produce penicillinase resistant penicillin. Okay, penicillinase resistant penicillin. Example is methicillin. So the Staph aureus, which was initially penicillin resistant, now became sensitive to methicillin. This is called as MSS. So penicillinase resistant penicillin is methicillin. The staph aureus which is susceptible to methicillin is called as methicillin sensitive staph aureus. Now again staph aureus became more intelligent. It changed the penicillin binding protein. So methicillin became resistant. That is what is MRS. Similarly, for any bacteria, we can tell about the resistance patterns. For example, E. coli or Klebsiella or Pseudomonas. Any gram negative, the most important thing is ESBL, extended spectrum beta lactamases. So all gram negative also produce beta lactamases. But what is this extended spectrum beta lactamases? Not only penicillin, it also cleaves cephalosporin. Okay, cephalosporins also. That's what is extended spectrum. CRO is carbapenem is resistant. Carbapenem resistant. So this is a new threat. A newer antibiotics still guidelines for CRO also. I'll tell it at the end. Okay, you understood this term now. What is penicillin?
Yeah.
Penicillin is producing organism. What is meant by MSSA? What is meant by MRSA? Okay. Right. So coming to the most important
What is
aspect of today's discussion, carbapenem resistant organism. Meropenem resistant. What color you want now?
what that? Right.
This is my favorite color, ruby color.
Okay.
Okay. So we'll start discussing this. Penicillin was the first antibiotic to be discovered, but sulfonamide was the first antibiotic to be marketed. Okay. Okay. It's like a flow only. Gram penicillin will kill gram positive cocci, gram negative cocci, gram positive bacilli, spirochetes. Some anaerobes. Okay. So what are the gram positive cocci? Staphylococcus, streptococcus, pneumococcus. Gram negative cocci are gonococcus, meningococcus, coraxella.
Menjococcus.
Gram positive bacilli, I told you the data.
Data.
Diphtheria, anthrax,
Anthrax, tetanus,
actinobacillus.
actinobacillus.
Spirochetes, I told you, syphilis, leptospira, borrelia. Some anaerobes, right? I will tell in different way also. Penicillin covers all cocci, irrespective of the gram status. It covers all gram positive, irrespective of the shape. Now tell me, now you know the organisms which are covered by penicillin. What are the possible infections it can cover? So gram positive cocci, staph, what are the infections caused?
Staph, mainly SSTI, bone and joint, bloodstream, and also the
Okay. Infected
neurosurgery.
endocarditis, right?
Oh.
Gram negative cocci, I told you. Gonococcus. So gonorrhea can cover.
Yes.
Meningitis, correct?
Meningitis also.
Meningococcal meningitis. Even streptococcus pyogenes, pneumonia, pneumococcus also causes meningitis. Gram positive bacillus is diphtheria, correct? Yeah. A for anthrax. T for tetanus. Spirochetes is syphilis. Leptospirosis.
Yeah. So
Borrelia is
basically,
Lyme's disease.
all these things penicillin will cover. All the organisms in the gram positive cocci, all in the gram negative cocci, right? It can cover.
Yes. So these are the organisms covered. Hence, these are infections where penicillin can be used. By penicillin, I mean the basic penicillin. Procaine penicillin, benzyl penicillin, benzathine penicillin, all this can cover. Even rheumatic fever. Rheumatic fever is caused by streptococcus pyogenes, right? You understood how I derived it?
Yeah.
Penicillin, the spectrum is these five. This five group of organisms have so many infections. So penicillin can be used for this.
But it may not be the drug of choice, right?
Yeah, may not be the drug of choice.
It can be used. What
Can be. Why
what
I
have
am
you?
telling this is, suppose if the patient we are not able to give a standard antibiotic, you are giving other, you are given other choice of antibiotics. Penicillin can be given. Still, that is to say, even penicillin is a drug of choice for cellulitis now. We can give penicillin for cellulitis still, if other drugs are not working.
Understood. Okay.
Right? So that is the aim now. So whenever you are learning antibiotics, don't learn this drug for this organism. Don't learn like that. Tell what are the possible antibiotics which can be given for that infection, so that you know how the thing works. You can switch between antibiotics, whether it will work out. You have written this?
Yes.
Yeah.
Yeah.
What is that
Now that's
word
one.
you said? It covers both all gram positive, irrespective of shape.
Covers all
Yeah.
cocci, irrespective of the gram staining. Okay, that is gram positive cocci, gram negative cocci. All cocci, irrespective of the gram staining. And it covers all gram positive organisms, irrespective of the shape. That is both gram positive cocci and gram positive.
Yeah.
This is about the basic penicillin, no? Or no,
Basic penicillin. Basic
not about the
penicillin is, I am telling the three forms of penicillin. Penicillin V, the oral penicillin, Pentits. Okay, penicillin V,
Yeah.
benzyl penicillin, benzathine penicillin. All the basic penicillins only I'm telling.
Sure.
Now there's one small problem with the basic penicillin. I told you about the resistance to Staph aureus. No, basic penicillin is highly resistant because of penicillinase producing organisms.
Okay.
So to overcome this penicillinase production only, what came next? Methicillin. Am I right?
Yeah.
Correct.
Yes.
Methicillin group is methicillin, oxacillin, cloxacillin, dicloxacillin. Okay. Just keep this in mind. So even though penicillin can be used for all these things theoretically, only two uses are there for penicillin in the current use. One is rheumatic fever. You know very well that penicillin V 400 milligram BD is used for rheumatic fever prophylaxis. Second use is syphilis. Syphilis also, we use benzathine penicillin. This is a question for you. Okay, 24 lakhs international units. One dose in primary syphilis. In tertiary syphilis, we give 3 doses. So syphilis and rheumatic fever are the two prime indications where we use plain penicillin, either penicillin V or injectable penicillin.
Can you show the dose again?
24 lakhs international unit, single dose IM in case of primary syphilis. In case of secondary, tertiary syphilis, actually early syphilis, primary syphilis and early latent syphilis, we can give 1 dose. 3 doses for late latent syphilis and tertiary syphilis. Early stages of syphilis, 1 dose. Late stages of syphilis like neurosyphilis, cardiac syphilis, we have to give 3 doses of penicillin.
How many
Rheumatic fever, you know,
months apart?
If
3 doses,
injectable
how many
penicillin,
months
3
apart?
weeks apart. 3 doses, 3 weeks apart. 3 doses, 3 weeks apart. So roughly 1 month.
Okay.
This month one, next month one, the next month one. Benzathine penicillin has to be dosed every 21 days.
Okay.
When the diphtheria pandemic came, diphtheria epidemic came, for them also we gave penicillin only. Injectable penicillin, prolactin. We gave procaine penicillin, sorry. I'm not sure of the dose. I think it is 10 lakh international units, Q638. When the diphtheria in 2019 one epidemic, for them also we gave penicillin as the drug of choice. Some tetanus cases I have seen during my PG. For those tetanus cases also we gave penicillin only. Procaine penicillin. So this is what, for all these infections, we can give penicillin. But rheumatic fever and syphilis definitely. Recent days, Diphtheria and tetanus also we have given. So for all these things you can give. Just remember that. But only problem is if you are suspecting a Staph aureus, don't use penicillin as the first choice because of penicillin is producing organisms. Now I told you what Staph aureus produces what syndrome?
Staph aureus will produce SSTI, bone and joint,
SSTA and BJA, right? SSTA and BJA. So if there is a skin and soft tissue infection or a bone and joint infection, preferable to use a penicillinase resistant antibiotic. So methicillin, oxacillin, or cloxacillin will be preferred. That's why you would have seen in snakebite cellulitis or bone and joint infections like a septic arthritis, we preferably use flucloxacillin, dicloxacillin, those things. Why? Because cloxacillin has a better coverage against Staph aureus because it overcomes penicillinase producing Staph aureus. This is what is MSSA. So methicillin, oxacillin, cloxacillin, flucloxacillin, dicloxacillin are used for MSSA. And what syndrome they are specifically used for? Skin and soft tissue infection, bone and joint infection. So if there's a staph, you are suspecting a staphylococcal cellulitis, a staphylococcal abscess, if you are going to give an antibiotic, we can give cloxacillin. That's the influence.
So mostly what do we give? Oxacillin.
In our hospital, dicloxacillin is given.
Okay.
In government setup, cloxacillin comes. 500 milligram IV Q630.
Sure. 500 milligram IV Q630.
Q630.
That is a cloxacillin.
Okay.
Right.
So penicillin, we moved from penicillin to the next category. Okay. Now, again, so what's the spectrum of penicillin? Gram positive cocci, gram negative cocci, gram positive bacillus, pyrochetes, and a few anaerobes. Okay. The main disadvantage is penicillins do not cover gram negative bacillus. That is the main disadvantage. So what happened is they created another group of penicillin called as extended spectrum penicillin. So what is that extended spectrum? Apart from these 5, if you add gram negative bacilli, it is called as extended spectrum penicillin. So what are the extended spectrum penicillins? In that, some groups are there. One is aminopenicillin. Aminopenicillin is a chemical group which includes ampicillin, amoxicillin.